Let's talk first about the class of drugs that shrink the prostate.
Okay. So, I'm going to take a step back because there was nothing to treat BPH with until some doctors developed the TURP surgery. 1930s, they started carving
TURP surgery.
Transurethral Resection of the prostate, and they started carving the prostate with kind of rudimentary techniques that have been refined over the years. So from the 1930s to late 1980s, that was it. That's if you had BPH symptoms that needed some therapy, you got a TURP.
So at most dinner tables, people get to talk about politics or other things. At my house, we talked about TURPs because my daddy did a ton of TURPs.
Yeah.
And they still do TURPs today.
It's different though, and in the 60s and 70s, since this was the only BPH therapy, this was the number one surgery of any kind performed in America, like more than hernias or cataracts or pure ear tubes or anything. So I just put that as a backdrop.
Okay.
In my residency training, which ended in 1991, that's all we did. And then right towards the end of residency, we were hearing about these drugs that were being evaluated. And they came along, and they came in the order of first the alpha blockers, and then the 5-alpha reductase drugs, the shrinkers. So let's just take them in that order.
Okay.
Because, and this is often the order that they're prescribed. We have alpha blockers, which alpha refers to a receptor, which is what leads to a muscle contraction, or in the case of a blocker, a failure to contract. So these are drugs that, name names, I guess, they started with Prazosin. We don't use that anymore. They went on to Hitrin and Cardura. Don't use those much anymore because they're less specific. They're more likely to be associated with low blood pressure. They're used as blood pressure meds. And then along came sort of the mainstays even today, Flomax, which is tamsulosin now generically, Uroxatral, which is alfuzosin, and another one that's yet to be generic is the Rapaflo, silodosin. And these all have the advantage over the earlier ones of being a little more specific. They target the specific type of alpha receptors in the prostate.
So this is that class of drugs you're talking about that relax the prostate.
So there's muscular tissue in the prostate, and there's glandular tissue. So the muscular tissue responds to the alpha blockers by relaxing to some degree.
Yeah.
Right?
Okay.
And the glandular tissue is unaffected by these drugs. So, and I should point out the fact that, prostates come in various combos, mostly muscular, mostly glandular, and a good old mix in the middle. It typically is that the smaller prostates are the muscular prostates, and the larger prostates are the glandular prostates. So we should talk about the shrinkers next. So anyway, these drugs are still in use, and as you said, people start them.
Relaxers.
They start them with some degree of enthusiasm. Here's a fix. And then oftentimes are, discouraged because of side effects, because of lack of real change, and sometimes just the hassle or the cost. These drugs, even if they're generic now, are very costly.
But for some guys, these relaxers work, and then they work pretty quickly.
That's one advantage. If they're going to work, they work within a couple of weeks. So it's a quick fix. But on that 35-point scale, they work to the tune of about 3 or 4 points. So how a man perceives that as impactful is still a little bit beyond me. But patients will come in and say, I was up 4 times a night, now it's 3, I'm happy. And we often wonder if that's really enough to get happy about. But then over time, up to 70% of these guys in a year will stop their drugs.
So these are still expensive. Some are generic, even though it's still costly. We talked about side effects of these relaxers, the alpha blockers. So what are some of the side effects of these relaxers that you don't like?
So, dizziness really concerns me in elderly patients. We can sometimes reduce the dizziness by combining these drugs with food, but dizziness could be literally a lethal side effect in an old person who then falls, breaks his hip, and gets pneumonia and dies. I mean, we see these things. Or just the fact that in an older person, these drugs don't quite get the job done and they're rushing to the bathroom. There's another opportunity for a trip and a fall.
Yeah.
Things like nasal congestion. I skipped right past the eyes, but there's something called floppy iris syndrome, which impacts future cataract surgery.
Yeah.
And then notoriously, these drugs impact ejaculation. They impede the amount of semen that is expelled at the time of ejaculation.
So that's when they came up with the word retrograde ejaculation?
Right, and in some cases it is retrograde, in some cases it's really anejaculation. Nothing happens at all, the whole system is sort of paralyzed. And I think men don't like that.
That was a polite way of saying it. I wouldn't like that. Especially if it's going the wrong direction.
Yeah.
Anyway.
There have been even some greater concerns just recently on the horizon, things like strokes that may be associated. So I think that not only do these drugs not do much in terms of the symptom profile, they also don't, and they have significant side effects, they also don't stop the progress of BPH. They don't change the natural history. They just sort of pull a patient back a little bit on the timeline, and then they continue forward. I think patients figure this out, as I said, because the symptom recovery of symptoms is not compelling for many of them.